Well, thank you. I want to extend my appreciation to Amy and Alessandro for including me in this session. I have no disclosures. Well, over the next several minutes, we're going to be looking at the role of an MDT in the management of patients with inflammatory bowel disease. We'll talk about the rationale and aims, who should participate, what requirements are there for an MDT, what types of cases should be discussed, and what kind of outcomes can we expect as a result of this approach. Well, the rationale for most of us that are involved in MDTs related to colorectal cancer, we understand that this is an important and integral part of the management of complex patients. The realities are that with these IBD patients, there can be clinical uncertainty. There's an expanding role with the shared decision-making on the part of the patient. The amount and complexity of the knowledge continues to grow every year. And with increasing healthcare specialization, it's important to get like-minded individuals together to discuss individual patients with an intent to ensure a higher quality of decision-making and improve the outcomes that our patients experience, whether it be in their clinical symptoms or their quality of life. Well, a group out of the UK conducted a Delphi survey where they had some 24 providers from more than a dozen institutions that weighed in on what the aims of an IBD MDT should be. They have primary and secondary aims, and the primary aims are really to deliver the best possible care and improve patient outcomes while advancing patient care. Multidisciplinary input is encouraged, where these experts share their experiences and a consensus management decision is arrived, and then this is shared with the patient. Secondary aims would include to reduce urgent or emergency surgeries and provide a forum where providers can learn more about the management of these complex patients, and really to ensure that patients don't fall through the cracks, that their appropriate follow-up is offered such that the patient can follow through the recommendations of the MDT. The same group looked at those members that they think should be integral to the MDT. And what they found was the usual stakeholders that you would expect with surgeons and physicians as well as support staff. But I've also added that in our MDT, we include psychologists or behavioral health people that are very integral in appropriately managing these individuals. Those people who would come on an ad hoc basis or extended members would be dermatologists, pediatricians, pharmacists, rheumatologists, and again, in the US, sometimes we'll have the obstetricians participate. On a larger level, the requirements, the primary requirements, the meeting should be conducted on a regular basis, whether that be weekly, monthly, but should be held in a kind of a confidential, quiet area where the members aren't distracted by other influences. There should be a designated coordinator that really helps to create the agenda and keep people on task with the results of the meeting. The institution needs to support time, protected time for these meetings, and understand this is part of patient care as opposed to administrative time. With each patient, a specific question needs to be posed and then addressed by the committee or team, and this needs to be documented in the patient's EMR. Secondary requirements, most people felt that a designated chairperson was helpful but not mandatory. Priorities are typically given to inpatients and those patients requiring urgent therapy, and a correspondence with the patient and their primary care physician is well advised. Those cases that are eligible for discussion, the priority discussions would go to complex cases that are looking at potential operation, those individuals that are presenting with a new diagnosis, patients that are starting or changing their biologic agent therapy, patients that have undergone a recent operation where prophylactic therapy may be warranted. Those are all come out of the UK Delphi inquiry, but what we in the US have also found appropriate would be patients with dysplasia or neoplasia, complicating their disease, a failed pelvic reservoir, and individuals that are pregnant. It's not that important that every case be discovered or discussed on an annual basis, or we really try to discourage individuals from bringing individual cases just to discuss. That can usually be done more on a one-on-one basis. Well, the UK has done a pretty good job about this, and there have been some surveys to look to see how or what impact that adoption has had. And in this survey of 111 UK providers related to fistulizing perianal disease, they found that almost all of the providers that were participating in the survey had access to an IBD MDT, but only about a quarter of the time were these perianal Crohn's disease cases discussed. And when it came to dysplasia complicating colitis, this was a global survey of some 300 providers related to this type of dysplasia. And what they found was that an MDT was routinely used in about 2/3 overall, but it was much more likely that a conversation would be held in a university setting as opposed to a non-academic center. And then lastly, coming out of Italy, there were 122 patients with chronic Crohn's disease, and they found that an MDT was used about 2/3, 3/4 of the time, but it really depended on what type of operation was planned, with a segmental colectomy much more likely to be discussed as opposed to someone undergoing a proctectomy. So what outcomes can be expected from a discussion? Well, we have 3 centers, one from Australia, where they looked at 261 cases over more than 2 years. The majority were Crohn's disease. On average, 2 or 3 issues were discussed per MDT. And most of these focused on complex decision-making, review of radiology images, or discussing new or worsening symptoms. They define success as implementation of a recommendation within 6 months of the meeting. And so using that definition, they had an overall success rate of more than 90%. And when you look at the impact of having follow through within 6 months, those individuals where there was follow through on the recommendations were much more likely to experience clinical remission and have resolution of the issue that was discussed at the MDT. But whether the recommendations were implemented or not implemented, a new unrelated issue was just as likely to arise. In a similar manner, the Mayo Clinic reported their experience of 90 patients over nearly 2 years. And what they found was there was an altered diagnosis in 12%, and using the same definition of success, the majority of the recommendations focused on medical therapy, with diagnostic and surgery being of lesser frequency. But again, if the recommendation was to undergo some type of diagnostic testing, that was implemented about 3/4 of the time. Medical therapy was almost universally employed, and the majority of patients went on to surgery if it was recommended. And then lastly, coming out of China, a single institution with almost 4 years of participation and some 276 patients. The diagnosis was altered 4% of the time. And what was interesting is looking at the surgical outcomes before and after adoption of an MDT for IBD patients, they found a marked reduction in the number of emergency surgeries done, the number of surgical site infections, the clinical recurrence rate, and the overall complication rate. So in conclusion, an MDT for discussing IBD patients has the potential to ensure a higher quality decision-making as well as improve clinical and lifestyle outcomes. The core members of the team should meet on a regular basis to address specific issues in priority cases, with the discussion clearly documented in the patient's chart. Many institutions have established these MDTs, but the resource appears to be relatively underutilized in some centers for a variety of reasons. And lastly, patients managed according to the plan are significantly more likely to experience resolution of the principal issue, enjoy remission of their disease, and experience fewer operative complications. So with that, I'll conclude and look forward to your questions. Thank you for your time.